Lots and lots of questions about block charting. I am going to go through everything with you. Vicki, our Epic partner, is going to demonstrate it for you. So hopefully once we get done walking through all of this, that'll answer a lot of the questions that you have. So block charting, we ended up pushing back the go live date. It is now going live on the 12th, so that's coming up this Tuesday. We kind of felt that the education for it needed a little bit more tweaking, so we were able to get a pushback so we could get some additional resources out. So high level overview of block charting, for those of you that aren't familiar with it, block charting allows nurses to document less when it comes to titrating certain medications. It's not every single titratable med. Medications like heparin and insulin are not in the list, but a lot of our more frequently, unfortunately, nicardipine isn't in the list either. I'm working on it, but it won't be in the list for go live. But a lot of our other titratable meds are in the list, and the purpose of block charting is to allow nurses to spend more time focusing on their patients rather than charting. It doesn't take away a lot of the charting, but it does take away some. It is for ICU nurses only. However, those nurses don't necessarily need to be in an ICU environment. For example, if an ICU nurse responds to a rapid on a med surg floor and levo needs to be started right then and there at the bedside, that ICU nurse can document in block charting, even though the patient is on the med surg unit, but it is only for the ICU nurses. So on the flip side, if you have a nurse who is not an ICU nurse caring for a patient in an ICU setting and one of these medications gets started, that non-ICU nurse, even though she is in an ICU setting, should not be using block charting. It is just for nurses who have that ICU competency. Okay? Block charting does not allow nurses to titrate outside of orders. So there are 3 different reasons that we can utilize block charting. It's for hemodynamic instability, initiation of sedation, and immediate postoperative recovery. However, nurses still need to follow their orders. So for example, if you have a patient who's hemodynamically unstable, you have an order, we'll walk through this in a minute, but you have this order for Levophed that you can titrate every 5 minutes by 1 to 5 mics. You have to follow that order. You still can't go from 5 to 20 of Levo in one shot. The nurse still needs to follow those orders and titrate every 5 minutes. The perk of block charting is you don't have to capture those every 5-minute intervals, okay? The other perk of block charting is you don't need to capture every therapeutic goal when you make these changes. And this is what is really the only perk for the Illinois people is, you have interoperability, which will capture all these changes in Epic automatically. But the nurse does not need to go in and do blood pressures every 5 minutes. Okay, the nurse needs to follow whatever your unit standards are. For most of us, it is every 15 minutes when you're documenting, or when you're titrating a med, you should document your blood pressures every 15 minutes. So if that is your unit standard, the nurse still needs to follow that standard. But they don't need to capture that blood pressure every 5 minutes and then a follow-up 5 minutes later and all of that. It really allows us to cut down on that. What I will tell you about this, and we're going to show this when we do the demonstration, is to watch your wording versus rate and dose, okay? What I'll ask you to do is document the starting rate, the ending rate, and the max dose. I can get in, it's a long story about the whys, but it is what it is. Nurses work in doses, not rates. So this will be a little bit of a challenge, but there is a way to get through it. So it'll be all right. So this is the top 4 sheet that we have created. It will hopefully go out in the next communication that Juliet puts out. Hopefully it'll be in there. Included in there is a link to the tip sheet that is located in Epic, which we will show you in a little bit. We had wanted to do a video demonstration for the nurses to watch. For a lot of different reasons, we decided that might not be the most effective manner to educate people. So what we did is we came up with block charting scenarios, one for Illinois and one for Wisconsin. And we took those 3 reasons where you would use block charting, the hemodynamic instability, intubation, and immediate post-op. And we created just a very small case study with screenshots then of what that would look like and what you would need to capture. And we did one for the Illinois side with the interoperability and then one for Wisconsin. So the educators and managers, and I think I have it, or maybe I don't. I thought I had it pulled up. Nope, not anymore. Anyways, the educators and managers can pull those up, share those with your staff, go through them, maybe share them at staff meetings. And we kind of felt that that might be the best way to go about it. So, Vicki, do you want to share your screen and kind of show?
Yeah, sure. I can do that now.
Awesome. Thank you.
All right. All right, let me know when you can see.
Yep, I can see it.
Okay, very good. All right, so I'm going to go over the mechanics of the block charting. The first thing I want to show is the access to the tip sheet. This will be valuable for the bedside nurse so they know how to locate that. I'm in the play environment. I will, in the chat, also leave some practice logins and where to go if staff did want to play around in the play environment and just see the different flow sheet rows. So the first piece, I'm going to go over to my top left over here and click on my dashboards. And we're going to want to go to the inpatient nurse learning home. And this is well put out there. Most folks should know this, where to find this, but if not, it's the inpatient nurse learning home in that top workspace. We would go to the documentation section, and then we would look for block charting, and that's right about over here. And I already have it open. So our block charting tip sheet would pull up over here, and we'd get that there. So that's how nursing can find that particular tip sheet. I'm going to go back to my patient, Karina, over here. This patient is located in a Wisconsin hospital, so there is going to be one little caveat that's different in Illinois, and I will call that out. So you need to go to your critical care monitoring flow sheet, and that should be available for all to find for their patients in the ICU. So block charting will live down here at the bottom. It's easy to find. You'll click on your contents over there, and it's going to drop you down to your block charting area. You will need to have your meds ordered to be able to see those here. So I did put a levo drip on this patient, and nursing can go to review that order in a number of different spaces. I'm just going to use manage orders, but there is many spots to look at your orders. And I'm going to go look at my levo drip over here. So I'm looking to say, okay, my MAP needs to be greater than 60. I see what my orders are. I just picked 5s because it was easier for the sake of demonstration. So starting dose is 5 mics. Titrate by every 5 minutes, and titrate by over there. And okay, so you'll look at your order over there. I'm going to go back to my flow sheets. I close up this little sidebar over here, go back to my block charting. Not a lot of flow sheet rows, but I'll come over to the block charting area, put my cursor there, and off to the right, you'll see the sidebar that'll give staff some guidance, and this is the same thing that's on the tip sheet. It's saying block charting is good for 4 hours, and some of the documentation parameters that need to be documented in the flow sheet. So the first one is the beginning of that block charting. So I'll go ahead and say begin over here. Next, you're going to get reason for block charting, and you'll have your reasons over here to choose from. So I'm going to say acute decompensation for this particular patient. Now, if you were in Illinois, I'm going to pull up that tip sheet to show what you would see next. There would be a box for pump integration utilized, and then that would be selected. Again, I'm in a Wisconsin patient. That's just where it's built in our practice environment, but you'd see that right underneath here. All right, let me pull up my little scenario that I had here so I can go along with it. Okay. So next thing we're going to need to put in here as we scroll on down, you'll see your block charting begin rate. You have to use a little bit of imagination here. You'd be doing pump integration in Illinois, obviously the manual charting in Wisconsin, and we're going to say that my blood pressure at around 9 o'clock, it tanked. We're now at 50/30, putting in my vitals over here, and my initial rate down here is going to be, and again, I'm just going by increments for ease of demonstration. So we're going to say I start at 15. My rate is 28.13. And to satisfy that begin block charting rate, I'm going to come right there. And you can see right over here that my rate is 28.13. So I'm going to put that in right now. And I'm going to file that away. Again, you don't have to file. That's just my preference. Of course, you'd address any BPAs. I'm going to say not accountable for right now. And once we hit that block charting, you'll see over here a few more rows open up. So that titration parameter used, this is where looking at that order is going to be really important. We're using MAP needs to be greater than 60. So at this point, this is the start of the block charting. Nursing will now focus on their patient care, using those guidelines from the policy in terms of documenting vitals and physiological responses. At this point, I'm going to go over to the work list. So block charting does need to have that end time, and it's good for 4 hours. So if I head over to the work list over here, there will be a task. And so it's 4 hours after you start the block charting. So what time is it now? It's 9. Oh, finalize block charting right over here. So if block charting was not finalized and it got forgotten about or what have you, there would be an option to jump to the flow sheets to go ahead and end your block charting. I'm going to go back to the flow sheets. All right, let me scroll on down to the bottom here. I'm going to add another column, and we're going to imagine that time has elapsed, and we're now ready to end this block charting. The patient is stabilized. We're going to say our final dose, and this is just in our example, is going to be 20 mics per minute. Okay. And we're coming down to the bottom here. We're going to say block charting end rate. If we look over here, our end rate is 37.5. Okay. And now the next piece will be max dose and max rate. And that's something nursing will have to be cognizant of. What was the max? And I'm going to say in this example, my max dose and rate was 50 mics per minute. So I'm going to put that in. And we're going to put for mLs per hour, 93.75. But that's something that's you're looking out for that particular piece of information. What was my max during that time? And I file that away. Oh, and I need to put my end. And put my end time in there. And then that should clear the task in the work list. And that would be in there. Kim, do you think that covered the nuts and bolts of it?
Yep. So again, you don't need to capture every single change that is made on the Wisconsin side. On the Illinois side, the interoperability will still pull through. But up here, that 9 o'clock to 9:28, the only vitals you will need to capture are the ones per your unit standard. So typically they're every 15 minutes. So you wouldn't have to do one with every single change. Tracy, you're asking if it can go live a little bit later. Nope. According, and you could probably speak to this, Vicki, but Epic go live things are always on Tuesdays.
Yeah, so there's like a routine schedule in there. So I actually, we did present this to our internal group of CI, and one thing I can say is, it'll be here, but folks won't be, if we don't know what it is and not educated, hopefully, people won't be. There's many things in Epic that we don't utilize, and hopefully once the education rolls out, then staff can go in there and begin using it when appropriate, or when they truly feel the need to use it at that time. So
yeah. And if the patient is unstable after 4 hours, you would end your block charting at 4 hours and then restart it at 4 hours and 1 minute. So then you would just add another column and restart it again. Yes, it does work for sedation and RASS. It'd be the same thing. when you are choosing. So in her example, we're using Levophed. If you were to use propofol, then the parameter used would default to RAS. Lori.
So is in the policy, is there a standard of how often we're going to document vital signs then? Is it going to be like every 15 minutes or?
Nope. For a couple of reasons. First of all, the DMV, so our policy was written based off of the guidelines that the DMV provided us. So we really copied their wording quite a bit to make sure we stayed in alignment. The DMV did not address documenting the, I always call it the therapeutic goal, but that parameter, they did not address how often that needs to be documented. They didn't say a word about it in there. So we kind of left our policy the exact same way. So our policy did not go against any unit standards or guidelines that might be out there. So we're kind of leaving that up to, at this moment, we are leaving that up to whatever your unit guidelines are, and when the DMV comes, that is how you will speak to it. Yes, Mary.
Sorry. So that actually is the entire reason why we're doing this, because in this case, we're saying the nurse is following, they're titrating based upon the order, but we're taking away the need for them to document that the blood pressure, the RAS score, assuming that if they're in block charting that they're following that. What it's supposed to do is allow the nurse to cognitively be present for the patient rather than worrying about the chart.
That's great. Thank you.
Yep. Yeah, so, and Tracy, I get that there's a quick turnaround time with regards to education. I did put the top 4 tip sheet in the chat. Let me, oh boy, I'm scrolling all over this. Let me know if you can't get to it. And I'll try and figure out another way to get that to you. We can also email it out to the group so everybody has it. The tip sheets
Kim, I have it inserted in the minutes.
Perfect. Thank you. Awesome. Thanks, Jean. It's also, the tip sheet is also live in Epic right now. So you can go into Epic and pull up the tip sheet and use that as education. A couple other housekeeping things about it. Yeah, Lindsay, about the Joint Commission, I want to say it's similar, but we might need to look at it a little closer.
It's similar.
No, it will not be available to the ER nurses. Unless they are also have a critical care competency and they are working they have access. This lives in the critical care monitoring flow sheet. So if they are an ED nurse, but they have an ICU competency on file and they are practicing inpatient, like they work between the 2 units, then I'm sure that's fine. But no, as of right now, this is not available to ED nurses. We wanted to see how this goes before building it out into the ED world. So this is kind of like a trial run. Yes, Mary.
Sorry. So the reason why there's wording in the actual policy for ED and for the PECU type areas, because at some point, as Kim just said, they may roll it out. We're just going to trial it in ICU first because we're the people that have gotten findings based upon this thing, based on titration.
Yep. Okay, so Lindsay, Jamie, go ahead.
Sorry about that. Just as we kind of look at this, I know collectively as critical care departments, titration and documentation have been kind of an ongoing struggle, whether it's titrating pressors, sedation, those kinds of things. Would it be possible that we could add this maybe as a follow-up to, like, at the next meeting, just to kind of hear if any departments have actually had to use this. I think my main concern with it is not having had this before. I think of COVID when we really were struggling with volumes and the types of patients we were seeing. I can only speak for my site, but our documentation was a little bit better. I mean, we did well with it. I struggled to find a scenario currently that I could leverage this with my team. I'm not saying it's not appropriate or can't be used, but it's making sure that our nurses really understand how important their documentation is. And this isn't, I don't want to say a workaround, but like a way for them to maybe not be really mindful of their charting. But if we could just follow up if there's sites that do use it and how it went and how their team did with it. Because with it being right in our critical care monitoring, the nurses will see it. You know, if it's live, it's there. We use this flow sheet a lot, and with it being embedded in there, they're going to see it.
Yep. Yeah, that's a great idea. I'll put it on the agenda for follow up, probably for the next couple of meetings. Just to see.
That would be great. Thank you.
Yeah, absolutely. And you know, the other thing that you guys can keep in mind is this is not mandatory. Your nurses don't have to do this if you know they're titrating up or down frequently on a drip. This is just an option available. So if, like in Jamie's case, she feels like her nurses are kind of have the process down, and this might, you know, wreck that hard work a little bit, tell them, don't use block charting right now. Keep doing what you're doing. I don't want you, you know, it's there, it's available, but we're not gonna go there right now. If you're concerned about not getting education out to your teams, you can tell them, hey, block charting goes live on the 12th, but we're not going to start this at our site until, you know, this date, because I need to make sure everybody gets educated. Like, that's all completely fine. It's going to be there. It's going to be available. Yes, Mary.
I don't know if you've already gone over this, and I apologize for having to step in late. Other things is that there actually is an audit tool. So there is a nursing audit tool. So you can really, I'm sorry, were you going to go forward and talk about that? All right, I'm going to shut up then. Thanks.
Yeah. So a couple other housekeeping things. The policy was live and they pulled it. A few wording things needed to be fixed. So they pulled it, they're rewording things, and it will go live in Policy Tech on go live date. You can search, I believe you can search either titration or block charting. So the policy is, it covers both med titration and block charting. So that should be able to find that in Policy Tech on go live day. The other thing, we just got this news this week, which is super, super exciting. There is going to be a report that you can run for block charting to see where you're at with compliance. It is a quality report, so it will be a day behind. So the hope is that this will go live on go live date. But if you were to run it on that date, it's looking back. That's how quality reports are. They look back 24 hours. So the report will actually be blank on go live date. So wait a couple days and then run it. Are you still, oh, I'm not sharing. I'm sorry. Let me quick, no, never mind. Why don't you, Victoria, show where to find that, and then I can share my, I forgot I'm not sharing.
Sure. Actually, I was going to answer Emily's question in the chat regarding the play environment. Emily, there is patients located in the play environment I go to patient list, Condell ICU, that's just the one they happen to be built in. You will end up seeing, let me go down here, block charting. What you will see is you'll see the pump integration utilized, but there is no way to see the intra-op functions. It's almost impossible to even test it when we're going live on things with intra-op, just due to it's like a third-party software that interfaces. However, if you do go into at least Condell or an Illinois unit, you get the pump rate integration one. So yeah, that's the best we got there. So, and then, okay, let me show you. I'm going to stop my share because I do have to go into the live environment. I just want to make sure I don't show patient data at first. Hang on 1 second. So I'm going to show where to find that report. It won't be live yet, but at least how to get there. Okay. Okay, so you want to go to your dashboard or anywhere where you find that SSRS reporting server. Some people actually have this built onto their desktop or in your apps down in the Windows menu, but anywhere where you find those SSRS reports. So I'm going to click on that, and that's usually on your system nursing dashboard. You may have it built into other things. Click on that, and it's thinking. Okay, it'll be a nursing report. However, when you're in here, you can actually just search in the top bar, and I'll type the name of the report number in here. If you chose to go to nursing, you certainly could go to the nursing tab, but you can go here. I'll put NUR, and it's going to be NUR 1010149, and we'll enter that in the chat. And so nothing's going to be there today, but this is how you would find that report in your Power BI or your SSRS. So let me put that report number in the chat. So report number, and then Kim, I'll stop sharing so you can go with your stuff.
Okay.
Okay.
Okay, so yep, this is what the report will look like. And you can either type in that NUR 10149 or you can just search block charting. In the service area, you can put your service area, then you can put your location, the start and end time that you want to look back for. This list over here on the left is what the data from the documentation and the flow sheet that's being pulled into this report. So it will tell you, you know, your patient's MRN, the start of the episode, the end of the episode, and then if there is a reason for non-compliance, it will be in here. If it is blank, that means that it is compliance, that all the pieces were there. So Kevin did a great job kind of building this out. As you are running this, if you want to see something different, you're a little confused what something means, reach out to me. I can always reach out to Kevin. This is just a beginning. But he said if you feel like you need something else or something more in this report, he'll see what he can do about building it. And then the other question that I've gotten from a lot of people is, will the providers see anything about block charting? And what I was told, and maybe you can speak to this a little bit better, Vicki, is MDs get a thing called the timeline report. And block charting will pull over into their timeline report, so they will be able to see it there. There was a provider on the Epic Build team for this who felt that that would be good enough for them. So again, if you're getting feedback from the providers that whatever they're seeing on this timeline report needs to be something else or something more or whatever, just let us know and we'll see if we can't change that build a little bit. I don't know that we can. There are a lot of limitations to building things in Epic, as we all know, but at least we have a report, so that's super exciting. So